course there. We probably do have time for one question before we move on to the next presentation. I mean, these are some incredible cases there that you're doing invasive techniques. What's your advice to all the young neurosurgeons online who wish to subspecialize in this area? What's your advice about starting with endoscopic training versus going with the standard techniques and then evolving their endoscopic skills?
Thank you. This is a comment for young neurosurgeon. At first, of course, it's better to familiar the microscopic skull-based approach, and then familiar with endoscope using another procedure. Endoscopic endonasal approach is a good case to familiar with endoscopic technique, and then combine the both technique. And in addition, the indication is very important. Subtemporal endoscopic approach, subfrontal endoscopic approach, and interhemispheric endoscopic approach. In all procedure, proximal side of endoscope, very safe space. So we can concentrate the surgical procedure. If the direction of the endoscope is not good, it's very risky procedure. We cannot check behind the endoscope. So indication is very important. This is a comment for young neurosurgeon. Thank you.
Excellent. Thank you very much. It's now my great pleasure to introduce Dr. Luca Ramos Lima from Brazil, who will present to us on strategies to maximize pituitary tumor removal. Over to you, Dr. Lima.
Hello, can you hear me?
Very well, thank you.
Okay. So I'd like to thank the WFNS, Dr. Handen, Dr. Orba, and Dr. Goto for the invitation. I'm going to talk about techniques to maximize pituitary tumor removal. Okay, so pituitary tumors are very common. They are now 15–20% of all primary intracranial tumors, and they are benign tumors. So they are frequent, and they're tumors that we can cure patients, young patients, that can come back to normal life and work. So this is important to understand the basics to work with these tumors. 1 minute, okay. So the principles of pituitary tumor surgery are a reduction of mass effect first. Why? Because we can preserve or restore normal neurological functions, especially vision, and also we can improve or maintain hormonal functions. But also, always possible, we try to remove all the tumor. So some tips. First of all, broad access. This is I put in the circle what we had the vision we had with the microscope. So if we do a limited access, we're going to have the camera and the instruments in a small space. We cannot maneuver and work with microsurgical techniques, and this is essential for this kind of surgery. So this is what we generally do, wide sphenoidotomies. Also, we remove the turbinates, and especially the right turbinate. And then we have this anatomy. It's essential to understand the position of the gland and also understand the anatomy around the gland. So understand the carotid arteries, the optic nerves. We always expose these structures, not just to visualize and understand the limit of the lesion and the gland, but also to have space to work with microsurgical techniques. So it's essential to understand the position of the camera during the procedure. So we are not going to put the camera in the center of our surgery. because of that problem with the instruments. So generally, the camera is in the lateral side. This is another reason to have big craniotomies, big opening. So the instruments have space. We work if the instruments are above, the camera is below. If we are working right, the camera is left. This is important when we change the position of the instruments, the camera, the surgeon with the camera has also to change his position. We always try to look the position of the gland in the MRI. This is almost always possible to understand. So this is one of the things that improved with endoscopy for these surgeries. We understand and preserve the gland during surgery. And so all of this to say that surgery is with 3 or 4 hands, and we work with microsurgical techniques. We have space to dissect tumor from the gland, and if possible, we work with extracapular dissections. I have a few examples. This is a microadenoma, a small microadenoma, a GH microadenoma. So I'll skip the beginning. And we see the gland in the right side. We start to dissect the gland from the tumor. Sometimes we have a pseudocapsule, so we try to maintain this plane, and very, very slow, we try to separate the tumor from the gland and from the cavernous sinus. And then we go a little bit further, and we can understand all the position of the gland and remove the tumor in one piece. It's not always possible, but this is something we have space, and we have to try to do it. Next case, this is what we generally see in pituitary tumors. I have a very soft tumor. In this case, I do not have the pseudocapsule, so we start removing tumor from below, and we have to go until the posterior part of the tumor, and then we have diaphragm going down. And lateral limits, we try to remove all the tumor. This is great when this occurs, but other times, this post-op, other times we have like a tumor like this, very similar, but here I have, sorry, see. Here I have pseudocapsule, and I have the gland. This is important. I have to understand the position of the gland. We open the dura mater, and now you see the posterior part, superior part is the gland. We start debulking the tumor, but we always try to find the plane between the gland and the capsule. Gland is posterior. You see here, this part is now the capsule of the tumor, and now we have a better plane to understand the limits of the lesion and remove it completely. Another case, this is a fibrous adenoma. This is like 5% of the cases. It's not possible to remove with the curette and then the section. So in a case like this, we have space, and we work with microsurgical techniques. We're going to reduce a little bit the size of the tumor so we can manipulate it. The gland is in the right side, superior in the right side. So after the booking, we find the gland and find the plane between the gland and the tumor, and now we can work easily with the gland preserved and remove most of the tumor in one piece with blind dissection and blood dissection, and always also with the scissor. I don't know if I have more time. I would just show a case of cavernous sinus, but the idea is the same. So always with microsurgical techniques. This is last case, but to finish, we always work with wide approaches. Sorry, it came back. Anatomy knowledge is essential. Training in the lab is essential. Also, it can reduce the learning curve. If I have an advice is to understand the position and handling of the camera and the instruments. We are always trying to work with microsurgical techniques and look for the gland in the MRI and look for the gland intraoperative to preserve it. Thank you for the attention.
Thank you very much, Dr. Lima. Very elegantly presented. In the interest of time, we'll move on to the next case and reserve the questions and discussion till the end. So it's now my pleasure to present Dr. Domenico Solari from Italy, who will present to us on endoscopic surgery for